dear friends, dear chairman, dear colleagues, we all know that about 36 or 40% of the ischemic strokes can be of cryptogenic origin, and this is the man who is wanted. If the PFO is present, and if present, is dangerous for the man, and if dangerous, should we close or should we treat the patients with medication? Here you can see how to verify, for example, the PFO in a young man, 34 years old young man who suffered an infarct probably caused by foramen ovale, and now you see the agitated saline reaction with transcranial Doppler, and you can see that during the injection, multiple microembolic shower could be seen over the MC registration during the Valsalva maneuver, proving, besides echocardiography that was also performed, that this gentleman suffers from a large PFO, and this can be the cause of his stroke. So, as we have heard from the previous lectures, the autopsy studies discovered high incidence of the occurrence of PFO. Every fourth patient might have smaller or larger. And it has been also verified that the significantly higher prevalence of PFO and atrial septal aneurysm could be found in cryptogenic stroke, although the yearly risk of cryptogenic stroke in healthy person is relatively low, and the relation between PFO and stroke is still controversial. In the French study, which was carried out on almost 600 people, and the follow-up period was 4 years in patients with unknown cause of stroke, all of the patients received 300 milligram aspirin, and as you see, 4 patients of the patients had risk and events, but they had no cardiac abnormality. And the patients who had PFO alone, they had less risk for ischemic events. And only those patients who had a concomitant atrial septal aneurysm and PFO, they had a high event rate. So they concluded that only the presence of both foramen PFO and atrial septal aneurysm can be a significant predictor. The PICSS study, this study will be repeated again later, on contrary, did not find any association between PFO alone and recurrent stroke or death, and no association could be found in patients with both PFO and atrial septal aneurysm. The atrial septal aneurysm is positive in many studies if the movement or if this aneurysm is larger than 1 centimeters. The SPARK was a population study and did not find that the PFO would be an independent risk factor for ischemic stroke, not in all the subjects. Again, a contradictory observation, more than 500 people, the presence of PFO significantly associated with cryptogenic strokes, both in younger than 55 and in the group of elder than 55 years. Here you can see, for example, that the PFO is much more frequent in the patients who are younger than 50 years old and suffers from cryptogenic stroke compared with the other group. This group of the patients have known cause of the stroke. And here in the elder group, elder than 55, you can see that also more PFO could be found in the patients with cryptogenic, much more than in patients who had not only a known cause but also a PFO. Very similar finding could be seen if you look for those persons who have not only PFO but also atrial septal aneurysm, but of course the frequency is much less compared with the PFO alone. As for the management, you could see that we have difficulties again with the evaluation of the previous observations. Why? Because the definition of recurrent event was different from paper to paper. They used non-uniform criteria for intra-arterial septal abnormalities. Sometimes the blinding was not absolutely correct, and incomplete accounting of associated risk factors, or the use of adjunctive therapies was lacking or was insufficient. We have already heard that then the French PFO as a study used by all patients 300 milligram aspirin, and interestingly in the patients with PFO the event rate was much less than in the patients group with no cardiac abnormality. The previously mentioned PICSS study evaluated the result on patients warfarin, and almost the same amount of patients was treated by aspirin, and no statistical difference could be found between aspirin and warfarin group. Here you can see the PFO, the PICSS study results again, warfarin and aspirin with the entire cohort, no significant difference between the warfarin and aspirin event, and the cryptogenic cohort also no significant difference. There was a trend, but the difference was not significant. So a meta-analysis performed at the beginning of the 2000 years found that the retrospective and dominantly observational study found the warfarin better than the aspirin, but the much well and better organized studies could not confirm this observation. And for example, in this well organized study, the warfarin was not superior over the aspirin. So, if there are questions regarding the medical therapy, what to do with these patients with surgical interventions? Of course, you can close it surgically, but it is accompanied with relatively high perisurgical complications. There are numerous different kinds of closing device. If there are so many different kinds and types of device, probably none of them is optimal. That's the reason why they should be tested. As I mentioned, the open thoracotomy is accompanied with a postoperative stroke, and this can be ranged between 0 to 3.5%. But don't forget that even the percutaneous device closure might have some complication, not only death, but tamponade, fatal pulmonary emboli by 1.5%, minor complication, arrhythmias is a frequent finding caused by the device, embolization caused by the device, device thrombosis, air emboli, and allergy, plus, of course, bleeding. And interestingly, there are observations that strokes occur after the closure. Why? Perhaps residual shunt, paradox emboli, thrombus may form, and another cardiogenic stroke source could be established by using the closure system. Or the worst scenario, if actually the diagnosis was not correct, and the PFO, the ischemic stroke was caused not by PFO, but with, for example, paroxysmal atrial fibrillation. My colleague has already evaluated some of the trials. I don't want to go into the details. This red have already been completed, but as you see, there are still some ongoing trials. And as my colleagues mentioned, this closure time did not find a benefit for the favor of the device. And this study has been performed on more than 900 patients, and the follow-up was 2 years and published 1 year ago. Here you can see the medical therapy arm and the device arm. And unfortunately, none of the subgroups showed any differences for the favor of male or female, or with the presence of atrial septal aneurysma, shunt size, or the therapy. How was the therapy with aspirin, with warfarin, or the combination of aspirin and warfarin? The RESPECT trial has been mentioned. There was not a follow-up, but they were waiting for the 25 primary effect. Almost 1,000 patients, and also no significant benefit associated with closure of PFO. The PC trial was also a multi-center trial, and with another occluder, the Amplatzer PFO, compared with the medical therapy, 4 years follow-up, and also did not result in a significant reduction of the risk of the recurrent emboli. And this study was published some weeks ago. Here you can see the results of the PC trial, although relative risk reduction was almost 80%, but it was not significant, similarly to the transient ischemic attack and death from any cause. So if we jump for the still valid American Stroke Association guideline, you can find these words: there are insufficient data to make a recommendation regarding PFO closure, and I should like to even strengthen or make a much more rigid conclusion or recommendation. The recently completed 3 randomized trials did not confirm this hypothesis. So perhaps there are some subgroups that may benefit with repeated ischemic strokes without known stroke source, a large right to left shunt or shunt at rest, together with atrial septal aneurysma. That can be the subgroup that can benefit, but on the other hand, my answer is that the recent data do not support the routinous PFO closure after TIA or stroke in cryptogenic stroke. Thank you very much. And if you want to hear more about PFO, please visit our annual meeting. We will speak a lot about PFO in Porto this year. Thank you very much.
Thank you very much for this excellent and nice documented presentation.